Module 7, the child with a gastrointestinal or endocrine disorder. Function of the GI system begins at birth, and it's really similar to the adult, but there's some limitations. For example, there's a reduced amount of liver and pancreas enzymes. Of course, the stomach has a smaller capacity, so this increases the speed of movement of the food through the GI tract, which in turn will make more frequent bowel movements. The cardiac sphincter, which is at the end of the esophagus, is really lax, so it allows for regurgitation in the infant. With the endocrine system, in the infant, it is adequately developed, but it's just immature, and it will mature in function as the child grows. With celiac disease, this is a gluten-sensitive pathophysiology. It's basically a defect of the metabolism that's precipitated by the ingestion of gluten, and it leads to malabsorption and gastrointestinal symptoms, in addition to impaired fat absorption. It is considered an autoimmune inflammatory disorder of the small intestine, and it will occur in about 3 to 12 out of 1,000 children, so really pretty common. These symptoms don't usually appear before the age of 6 months to a year or even later in life. There is an insidious onset. The client may have chronic diarrhea with steatorrhea, abdominal distension and pain, progressive malnutrition with a failure to thrive. Vomiting and anorexia can also be present. And if it becomes severe, we may even see delayed growth and development, a distended abdomen, thin and wasted buttocks and legs. So to diagnose, we do a screening. We may trial a gluten-free diet, and if we see improvements in symptoms, then they probably do have celiac disease. We can do a biopsy through an endoscope or a serum screening of the immunoglobulin G and A anti-gliadin antibodies. To treat it, basically, this is going to be a lifelong gluten-free diet. So these clients' parents are going to require dietary and nutritional counseling. As nurses, we need to provide education about the diet, and the family has to learn to read food labels. Encouraging the child to eat a diet and continue that diet, especially once they start going to school and they're with other children, can be very difficult because children like to be the same as other kids, and doing something different can be very, very difficult for them. As far as the cleft lip and cleft palate, cleft lip will happen 3 out of 10,000 births, and it is more common in the male children. Cleft palate is about 6 out of every 10,000 births, and this one is more common in females. We may just see a cleft lip, we may just see a cleft palate, but sometimes they will appear together. There is an unknown cause, but it might have some genetic components to it. So basically, this is a failure of the primary and secondary palates to fuse. We may just see that simple notch in the vermilion line as indicated in the picture A. It may extend to the floor of the nose. It may be unilateral or bilateral. The cleft palate is often accompanied by nasal and dental disorders. Basically, diagnosis is by physical appearance. It may require surgery, and that timing of surgery will vary among the surgeons and the extent of the deformity. Repair will be needed to ensure intelligible and pleasant speech and proper nutrition. and it can require several surgeries to completely correct that deformity, depending on the extent of the deformity itself. So, question, true or false? The optimal time for repairing a cleft palate is between 6 months and 5 years of age. And this is true. So the pylorus is a muscle that controls the flow of food from the stomach to the duodenum, or the small intestine. Pyloric stenosis happens because we have hypertrophy of that circular muscular fibers of the pylorus with severe narrowing of the lumen. And the pylorus is thickened to as much as twice its normal size. It becomes elongated, and the consistency of the tissue then resembles cartilage. The stomach will become dilated because of obstruction. This is basically a congenital defect. These infants will start out eating very well. They'll gain weight, and then they'll start having occasional vomiting after meals, and that vomiting increases in frequency and force until it becomes projectile vomiting. The emesis will be sour, undigested food. Obstruction is a mechanical issue. The child is still hungry. They're not getting the food. It's coming right back up. So the baby becomes irritable, loses weight, becomes dehydrated, may develop alkalosis, constipation, scant urine. We may see visible gastric peristaltic waves in the abdomen. Diagnosis will be made by the clinical evidence, and treatment will require a pyloromyotomy, where they actually go in and start snipping some of that tissue. So, question. You're caring for a 2-year-old with gastroenteritis with severe diarrhea. What nursing action would be important in dealing with this child's diarrhea? Would we reduce the risk of infection, increase adequate nutrition, decreasing skin integrity, or preventing dehydration? And it is preventing dehydration. So intestinal parasites are often brought about because of that hand-to-mouth practices. It contributes to those infestations. We have several different parasites that may be involved. The pinworm infection will invade the cecum, and articles are contaminated with pinworm eggs, and this spreads the pinworms. The child will ingest the eggs. They grow and mature in the cecum. When the adult female is ready to lay eggs, it crawls out of the anus and lays eggs on the perineum. The child will have scratching and itching on the perineum, and then collects those eggs under the fingernails, which causes reinfection and/or spread to other people through clothing or bedding, food, and toilet seats. Eggs can also float in the air and be inhaled. Life cycle of these worms are about 6 to 8 weeks. And again, intense perianal itching, restlessness, irritability, poor sleeping, and bedwetting are common symptoms. We diagnose by using a cellophane tape to capture the eggs from around the anus, and we examine it under the microscope. And you might also see some adult worms there. Uh, we place the tape on the microscope slide and take it to the lab. We treat it with anti-helmintic or vermifugal treatments for the entire family because they are easily transmitted, and repeat it in 2 to 3 weeks to eliminate any newly hatched parasites. As nurses, we teach preventative care, which includes washing the hands after bowel movements and prior to eating. along with other hygiene steps such as properly cleaning the clothing and bedding, changing the bedding frequently, and washing in hot water. So roundworms are large intestinal worms found only in the humans. Infestation will be made through contact with contaminated feces and can also involve the liver, lungs, and digestive tract. Bowel obstruction can be present, and if so, it creates serious problems. Generally, there's no symptoms in ordinary infestations, but children might show malnutrition and weight loss. We identify these roundworms with microscopic studies. Excuse me. We treat it with medication and improved hygiene practices. Hookworms live in the intestinal tract and attach to the wall of the small intestine. Clinically, usually they only enter the body through bare feet. They produce itching and dermatitis on the feet. We may see anemia, listlessness, fatigue, and malnutrition. We diagnose by looking under the microscope a sample of the feces. Again, treat it with medication and a well-balanced diet. As far as nursing, make sure we educate for prevention and proper nutrition. Giardiasis is a protozoan parasite. It's not necessarily the worm, but it is a common cause of diarrhea in travelers. We can see clinical manifestations of diarrhea with foul smelling and fatty stools, weight loss, and abdominal cramps. We diagnose it by looking at the stools underneath a microscope. Again, medication would be involved in the treatment. Nursing care, we need to educate, teach hand washing and avoiding contaminated water and using standard precautions. Failure to thrive might be that non-organic failure to thrive or the rumination disorder, usually caused by a disrupted family relationship or a lack of mother-child attachment or absence of the father. It might be an environmental issue such as a knowledge deficit, marriage problems, stress, or poverty. It might be caused by caregiver mental health disorder such as depression or substance abuse. These babies are often labeled difficult or irritable, but the problem, again, is interaction between the baby and the family. There's often serious below the average weight and height. They have poor muscle tone. They're emaciated. They have loss of subcutaneous fat. They're immobile for long periods of time. These babies may smell sour due to frequent vomiting and be unresponsive to or avoid cuddling or verbalization or vocalization. They require long-term care to treat not only the physical, but also the psychological aspects. It's really important for us as nurses to avoid judgmental, stereotyped feelings of those family caregivers. The esophageal atresia and tracheoesophageal fistula is basically an absence of a normal body opening or an abnormal closure of a body passage. With esophageal atresia, there may or may not be the tracheoesophageal fistula, excuse me, which is basically an abnormal opening between the esophagus and the trachea. So in other words, what goes down the esophagus can go into the trachea and vice versa. These clients, these babies are going to have frothing, excessive drooling, and periods of respiratory distress with coughing, choking, and cyanosis. It will require surgery, although it might be done in stages. The important thing is to prevent mucus aspiration and respiratory distress. And with the tracheoesophageal fistula, gastric contents or foods and liquids, again, can easily be aspirated into the lungs. These babies require IV fluids for hydration and TPN for nutrition. They may need a gastrostomy tube and drainage of the proximal esophageal pouch. The imperforate anus is basically a blind rectal pouch, and there's no anal orifice. So they just didn't quite fully develop. They may also have a potential fistula between the rectum and vagina in females, or in males, the rectum and the urinary tract. We may also just see a dimple, and these babies will develop abdominal distension because there's nowhere for that stool to go. It does require surgery, and the extent and type of surgery is going to be dependent on the defect. Some of these babies will require colostomies. It's very important for nurses to teach colostomy care if this is what happens with the newborn. Type 1 diabetes mellitus is usually diagnosed between the ages of 4 and 15 years. Management in children will differ from that of an adult, and it needs to be geared to the child's developmental age. Again, this is an autoimmune destruction of the beta cells of islets of Langerhans in the pancreas. So it's basically the cells that secrete insulin. It can be a genetic factor that contributes to this, or an acute infection during childhood. Classic symptoms, once again, polyuria, polydipsia, and polyphagia, accompanied by weight loss or a failure to gain weight, a lack of energy with an abrupt onset. It will progress to diabetic ketoacidosis if it's not diagnosed. So early detection and control are going to be key in postponing or minimizing later complications. It is diagnosed also by routinely monitoring children that have a family history of diabetes mellitus. The glucose tolerance test is often done in the adult, but it's not successful in children. They may vomit the glucose that may be swallowed, and we just don't get good results. So insulin therapy will be required. They have to do appropriate diet and exercise in addition to manage their diabetes. The goal is to keep their A1C at 7.5% or less, and we want their blood glucose levels between 80 and 130. Their insulin dosage will be adjusted according to those blood glucose levels. Their dosages are going to be individually regulated to keep their blood glucose levels as close to normal as possible. Again, we need to be aware of those hypoglycemic reactions that can be caused by insulin overload due to a change in the body's requirements, carelessness in the diet, or increased exercise. So we may need to encourage these children to be taking a snack prior to heavy exercise. Symptoms of hypoglycemia: the tremors, the pallor, sweating, tachycardia, fatigue, lethargy, headache, seizures, coma, irritability, agitation, erratic behavior, tantrums, And hypoglycemia in children frequently will happen in the morning. So in the hospital, it's really important to observe the child every couple of hours, initially noting that messy bed. Once they kind of develop their or get their disease under control, then we may not need to monitor them quite so much. But again, make sure that we are giving them the appropriate education on how to manage their disease process. As far as insulin administration, they might need extra insulin throughout the day, and this is frequently done with the pumps in children. Careful blood glucose monitoring at least 4 times a day is necessary, and we need to consider the unique needs of the adolescent because this is an extremely trying period of life anyway, and they have to work from dependence to independence. So then they start to rebel against the control that their diabetes requires. They should be allowed to continue managing their own treatment as they're able to, but they need to understand uh, they need understanding people who will respond with care. Sorry. And phenylketonuria, or PKU. This is a recessive hereditary defect of metabolism, and if untreated, it can cause severe intellectual disability. It is uncommon, but it is a very preventable issue. Uh, having someone who's mentally disabled the rest of their life, or having PKU screening at birth so we can determine if they lack the enzyme that normally changes the phenylalanine into triazine. These kids are going to have frequent vomiting, aggressive and hyperactive traits, severe progressive mental disability, convulsions, eczema, and a musty smell to the urine. But now all states require the screening, which is called the Guthrie inhibition assay test. It's done after the ingestion of protein, and if it's positive, further testing will be required just to confirm. But treatment is relatively simple. They take the formula low in phenylalanine. They continue with a diet that is low in phenylalanine, which is found in most grains, meat, fish, dairy products, eggs, nuts, and legumes. But if we avoid that phenylalanine, then we can avoid all of these issues. As far as nursing care, these clients need to be referred to a nutritionist to assist the family. The family and child will need support as the child gets older. And if the woman wants to get pregnant, she will need to follow the diet at least 3 months before getting pregnant, and routine blood testing will be required. And now it is time for the post-test.